That's a holy grail, right, to identify a biomarker of folks who are going to respond to checkpoint blockade. And some of the data that I presented at the Miami meeting actually addresses one specific biomarker, and that's PD-L1. So the thought would be if you're going to use an antibody that targets the PD-L1 axis, you would need PD-L1 expression to respond. And in fact, the data is somewhat mixed on that, and I think a lot of us in the field believe that in fact PD-L1 expression may not ultimately end up being the ultimate biomarker because it's so fluid. If you're stimulating an immune response, the T cells come in, they release interferon gamma, that causes PD-L1 to go up. So it's very dynamic. So the data that was reported out this year in the breast cancer field was correlative studies done in the trials that I alluded to earlier. So some companies are looking at PD-L1 expression, and in fact that cohort B for the Keynote trial looking at pembrolizumab did in fact suggest that if patients had not previously been treated and they had PD-L1 expression, they were going to have a higher response rate. The atezolizumab trials actually were looking at PD-L1 expression on immune cells, so not PD-L1 on the tumor, but PD-L1 on other immune cells in the microenvironment. And then there was additional data this year that came out suggesting that in fact maybe we don't need to be looking for PD-L1, but looking just at the presence of stromal lymphocytes. And so that was data presented at the ESMO conference suggesting that the presence of stromal TIL may actually predict response to therapy. My thought is that it's going to be complex and there might be multiple biomarkers that we'll need to look at, but certainly that emphasizes the need to be doing really good correlative studies for the patients that are on our trials.